Laura Boitano. I'm one of the vascular surgeons. I'm here with Lisa Aiello.
Sorry, I'm Chatty Cathy. Saying hi to everybody.
She's the vascular nurse practitioner, yes. And we work together. We're both part of UMass and Harrington. So this is us. We have a site in Charlton on 10 North Main Street off of Route 20 right by the CVS. We work together and see patients on Tuesdays and also have a vascular lab at our location. So what is vascular surgery? Vascular surgery is the surgery of blood vessels that's everywhere in your body except for your brain and your heart. So brain is neurosurgery, heart is cardiac surgery, and we kind of take care of everything else, both the arteries and the veins. Our objectives today is to, one, understand who is at risk and how to prevent complications from vascular disease. We'll learn about abdominal aortic aneurysms, the screening for those, management, and rupture prevention. We'll talk about diabetes and peripheral arterial disease, and a focus on amputation prevention, and then we'll finish the talk with varicose veins with simple tips to reduce symptoms as well as complications. So what is an abdominal aortic aneurysm? This is an enlargement in the diameter of the aorta in your abdomen. The aorta is the largest artery in the body. It travels from the heart through your chest and into your abdomen. And we see this enlargement in the aorta due to weakening of the wall. So just like if you think of a balloon, as it gets larger, the balloon weakens and eventually pops or ruptures. The same thing can happen with very large aneurysms. The normal aorta measures less than 2.5 centimeters. We consider slightly enlarged as being 2.5 to 2.9 centimeters. People that present with this, we just keep an eye on them. We put them in surveillance, and then we think about an abdominal aortic aneurysm as an aorta that measures greater than or equal to 3 centimeters. What do we know about aneurysms? Well, every year, 200,000 people in the United States are diagnosed with abdominal aortic aneurysms. About 1.1 million adults are living with aneurysms, and it's common in the older population. So very uncommon to diagnose a patient who's less than 60 with an aneurysm, but much, much more common as you get older in age. And so the patients who are at risk for these are people who have ever smoked in their lives, either currently or prior. And we say that if you've smoked about 100 cigarettes or more, you're at risk for an aneurysm. Men obtain or have aneurysms more commonly than women. As you get older, like I mentioned, they are more common. There is a genetic component to aneurysms, so if you have a family history, a first-degree relative with an aneurysm, that increases your risk. If you have a family history of an aneurysm elsewhere, that increases your risk. Or if you have a family history of something called an aortic dissection, or you yourself had a dissection, that increases your risk. We also think about coronary artery disease and peripheral arterial disease as being risk factors as well. So who should be screened for an aneurysm? So patients who are 65 to 75 years old, who either have a family history of aneurysm disease or who have smoked in their life should be screened. In men, there's really no controversy around that, but in women, because aneurysms are less prevalent, there are some guidelines that suggest that women don't need to be screened if they have a history of smoking. But I recommend it to all of my patients because screening is non-invasive and very easy, and I see the complications associated with aneurysms. So my recommendation is for men and women, 65 to 75, history of smoking or family history, to get screened. We screen with an ultrasound. It's similar to what you see on this slide. We have patients lay down, they're fasting for the examination, and we just put an ultrasound probe on their belly and can see the aorta. And this is who we mentioned. No, it's okay. And those are the people that we want to be screened, like I mentioned. And why is it important to screen? Well, we know that most patients who are diagnosed on a screening ultrasound have a small aneurysm. And this is really beneficial because we can monitor this aneurysm over time and place patients in surveillance. Small aneurysms have very, very low risk of rupture. And I usually tell my patients who have small aneurysms, you don't need to change your lifestyle. You don't need to stop exercising. You just need to continue in surveillance, eat healthy, be on certain medications, but surveillance is really the key to rupture prevention. And we know that rupture is associated with death and poor outcomes. So our goal is to really prevent rupture. So let's say you're diagnosed with an aneurysm. It doesn't meet size criteria for repair. What should we do? The first thing is, if you're smoking, it's really important to quit smoking, because smoking is the biggest risk factor for aneurysm growth. It's also important to manage your other comorbidities like high blood pressure, high cholesterol, diabetes. Really important to keep those under control. And we promote moderate physical activity. So go outside and walk. That's all great. You don't have to stop that. It doesn't precipitate rupture and is totally okay. And what are the symptoms to look out for? If you know you have an aneurysm and you develop severe abdominal or back pain, that is a reason to seek medical attention. Most patients who have aneurysms are asymptomatic. However, if you do experience any of those new symptoms, we recommend that you go to the hospital. We treat men when the aneurysm reaches 5.5 centimeters and women when it reaches 5 centimeters. And the reason for that is that women rupture at smaller diameters than men. So we treat women who are healthy at smaller diameters. We also treat rapidly expanding. So if in surveillance we notice that your aneurysm has grown very quickly, we may treat you before you hit that 5.5 or 5 criteria. If there's an evidence of infection, we'll treat that aneurysm. And if you develop any symptoms related to the aneurysm, or of course if you have a rupture, we will treat you no matter the size. Surgery can be either open, we consider that maximally invasive surgery, or minimally invasive surgery where we make really small incisions in the groin and deliver a stent graft to exclude the aneurysm. And depending upon your health and your comorbidities and the anatomy of your aneurysm, we may recommend one versus another, but you should know that in the United States, many, many more patients are getting the minimally invasive option versus the open option. We have a special program at UMass that uses artificial intelligence and a nurse navigator to enroll all patients who are seen in either the Charlton or Worcester location into our surveillance program. So if you get an ultrasound at Harrington or in Worcester or in our Charlton location, you're automatically enrolled into our program so that we can keep an eye on the aneurysm. A lot of patients are lost to follow-up because surveillance has to occur over time. So this program helps to reduce patients who are lost to follow-up. We have a special partnership with the Lung Cancer Screening Center at Harrington Hospital, and we're making sure that more patients are screened who are appropriate. So we're really trying to reach as many patients as possible who qualify for screening, because we know screening and surveillance are the most important things to prevent rupture. Our screening and surveillance program, that artificial intelligence program that I was talking about, has reviewed over 9,000 imaging studies, and we follow 2,500 patients with aneurysms in surveillance currently. And due to this program, we've identified patients who were either lost to follow-up or didn't even know that they had an aneurysm, and it's resulted in 21 operations. So this is a really great program to ensure that patients who are appropriate for operations receive them, and ensure that patients are followed long-term to prevent rupture risk. We have a Center for Complex Aortic Disease. It's one of only 10 centers across the country that has special investigational device exemption through the FDA to treat very, very complex aneurysms. We do this surgery in Worcester, and it's a really unique program that basically we can take patients who have aneurysms throughout their aorta and treat them regardless of how complex that is. So it's really wonderful that we can offer this to our patients. These are just some imaging studies of aneurysms and patients who have been treated. You can see that we can place stents throughout the aorta. We have stents into the main branches going out to the kidney arteries, the arteries that supply the intestines. So we can really make these complicated plans for patients who need them. Before I go on to peripheral arterial disease, does anyone have any questions or want to talk more about aneurysms?
I just wanted to ask you, when you're doing the surveillance part,
Yes.
how frequently are people getting with the MRI? How often?
So it depends on the size. So if you're 3 to 4 centimeters in size, we will do screening about every 3 years. If you're 4 to 5 centimeters every year, and 5 to 5.5 every 6 months. So the larger you get, the closer we screen. Yes.
You said that you're working on everybody that was diagnosed. How long have you been tracking the people? Because I was diagnosed with an aneurysm 6 years ago.
Uh-huh.
I'm just going for surgery for it next month.
Oh, wow.
I was just wondering if I was part of your study that you can.
So what we did was, starting in 2021, we looked at the last 10 years of patients who had imaging done at UMass in Worcester. And we've contacted many of those patients or their primary care doctors. And now we're starting to look at the patients that had imaging studies at Harrington Hospital. So I'm not sure if you were one of the patients.
I was at Harrington
okay.
6 years ago.
Okay. So we'll probably stumble upon your imaging sometime soon. But it's great that you were in surveillance and that when you met criteria, you're getting the appropriate surgery.
Yeah.
You want to ask about the kidney?
No, go ahead.
Oh. I guess it is going to be me. I warned you about him. They also found 2 small aneurysms in the iliac going to the kidneys.
Uh-huh.
Now, would you handle that, or is he going to see a kidney specialist?
We usually handle all of the aneurysms. Yep.
So you would be seeing her. Okay. My doctor. I love it. It's very nice seeing you here today.
What is the chief cause of a aortic
Aneurysm?
wall to rupture or to weaken?
So size is the biggest risk factor. The larger that the aorta grows, the weaker the wall gets, similar to that balloon phenomenon where you blow up a balloon. The larger that it gets, the thinner the lining, and it's more prone to bursting. The risk factors for aneurysm growth are, number one is smoking, and high blood pressure certainly contributes to it. Atherosclerotic disease like cholesterol is another contributor. We know that being male is a risk factor for just developing aneurysms, but being a woman is a risk factor for rupturing at a smaller size.
Thank you.
Mm-hmm.
Do you scan over 75 years old?
So the current guidelines suggest that if you are older than 75, you should not be scanned, and that's just looking at population health. I think you can have that discussion with your doctor to talk about the risk benefits of screening. I will often screen my patients who are over 75 if they haven't received it, especially if they're healthy enough and I think that they have longevity going on.
What does the scan entail?
The first scan that we do is an ultrasound. We do that in the office, so you'll often go to our vascular lab, get that ultrasound, and see us right afterwards. As the aneurysm gets larger, we may get a CAT scan to get a better sense of the anatomy and plan for surgery. So the ultrasound is non-invasive, there's no radiation, there's no contrast, and so that's why you can kind of stretch the guidelines a little bit if a patient's healthy. Any other questions before we move on? These were great questions.
So
yes.
if you're in that age group, should you just automatically say, I'll get one? Or do you have symptoms that you should be looking for
Most
to say
patients.
whether you get it?
So most patients don't have symptoms, and if you do have symptoms, that can mean that you have a more urgent situation going on. And so I recommend, regardless of symptom status, if you qualify for screening, to get screened. So once you hit 65, if you have a family history or a smoking history, get screened.
So if you have none of those,
Then you don't need to.
Then just go on life.
Yeah.
Because I don't have any of those, but I am in the age group, you know.
Then your risk of developing an aneurysm is low enough that we don't recommend routine screening. All right, we'll move on to peripheral arterial disease. So what is it? So peripheral arterial disease or peripheral vascular disease is the buildup of plaque or cholesterol or calcium within the arteries that supply blood flow to the legs. Oh, sorry.
No, that was me.
There are risk factors, like there are risk factors for abdominal aortic aneurysms, there are risk factors for peripheral arterial disease. As you get older, that increases your risk. Certainly smoking is a huge risk factor, diabetes, huge risk factor, cholesterol, obesity, lack of physical activity, those are all big risk factors. But I would say the patients in my practice that I see primarily have a history of smoking or have a history of diabetes. Those are the two major risk factors. And this is a spectrum of disease. So there are many patients who have some blockages in their arteries but are totally asymptomatic and they live their life and they are not affected at all by their peripheral arterial disease. And that's a lot of the patients with peripheral arterial disease. As it progresses and it gets worse, patients will develop something called claudication or pain with walking. And what patients will describe is that they walk, let's say, 2 blocks, and every time they walk 2 blocks, they get crampy pain in their calf, and that stops them from walking. But as soon as they rest for 1 to 2 minutes, sometimes longer, that pain goes away. And that's because there's a mismatch of the supply and demand of oxygen to the muscles of the leg. And you build up lactic acid and your muscles are basically saying, I need more oxygen, I need more blood flow to keep going. And patients will often describe that pain in the calf. They may also say that their thigh and buttock are cramping with walking. But what you should know is that patients that have just claudication, so at rest they have 0 pain, they just have pain with walking, your risk of progressing to needing something like an amputation is exceedingly low. This is a pretty benign condition, and this is a condition that we can treat very effectively medically without undergoing surgery. And it's really all about risk factor modification. On the other end of the spectrum is something called chronic limb-threatening ischemia. And this is patients who will say, I have pain at rest. So this is pain in their forefoot that wakes them up at night. And they'll often say, when I dangle my leg next to the bed, that pain gets better. But as soon as I lay down, I have severe pain, keeps me up at night, very debilitating. And you can imagine that that's a more serious condition because just at rest, their foot's not getting enough blood flow. Another spectrum of chronic limb-threatening ischemia are ulcers and non-healing wounds. And this is a totally different patient population. So if you have pain at rest and you have ulcers that are not healing or cuts on your foot that haven't healed in a month, your risk of eventual amputation and death is much, much higher than the patients with claudication or just pain with walking. So two very different, almost disease processes, I think of. And this just goes through the same thing I talked about. It's a spectrum of disease. You have anywhere from asymptomatic patients that don't even know they have blockages in their blood flow to patients who have such severe blood flow issues that they require an amputation. And we treat patients throughout the spectrum. It's very, very common in the United States. It affects 12 to 25% of the United States population. We know it increases with age, and 8 to 12 million Americans are living with peripheral arterial disease currently. Majority of patients are asymptomatic, and we know that there's an association with other atherosclerotic disease processes like coronary artery disease. So if you have peripheral arterial disease, the odds that you have coronary artery disease is much, much higher. How do we diagnose peripheral arterial disease? Well, we do something called an ankle brachial index. This is a non-invasive test where essentially we take the blood pressure in the leg and compare it to the blood pressure in the arm, and they should be about equal. As the blood pressure in the leg drops, so does that ankle brachial index, and that tells us that you have peripheral arterial disease. And we think of peripheral arterial disease as being a ratio of 0.9 or less. And this just tells you the spectrum of peripheral arterial disease. So we have normal, that's 0.9 to 1.2. Patients can have really severely calcified vessels, so calcified that we can't actually take a blood pressure because we can't compress them with the blood pressure cuff. And then we have that claudication that ranges from usually an ABI of 0.7 to 0.9, and then lower than that is what we think of that chronic limb-threatening ischemia. So really, to diagnose it, it's non-invasive, very easy. We do that in the office and we see you right afterwards. It tells us a lot about what your blood flow is doing to the leg without too much time either. It's a very fast test. So what do you do if you're diagnosed with peripheral arterial disease? Well, the first thing is, if you're smoking, it's really, really important to quit. And I tell my patients that it doesn't matter what you do to quit. You can use the gum, you can use patches, you can use medication, you can use hypnosis, you can, there are so many ways to quit, but it's just about trying something. And many patients have multiple attempts before they're successful, so I try to encourage patients to kind of expect that, and so that they're not too discouraged when, there's a hiccup. Exercise, walking, super important. Diet, very important. Risk factor modification, like we talked about before. Blood pressure control, getting your diabetes under control, cholesterol under control, all very important. And we'll talk to you about certain medications that are important in the management of this, like aspirin, anastatin, or cholesterol medication. And then there's another medication called cilostazol, which can work to help to improve your walking distance. And this is something that we talk about in the office. So what we know is that the first line treatment for patients with pain with walking or claudication related to peripheral arterial disease is a walking program. We know that patients who are sedentary, so they don't walk, they smoke, could quadruple their walking distance with quitting smoking and starting a walking program. And so that's why any patient who comes to my office with peripheral arterial disease and claudication, I prescribe them a walking program. We do prefer walking over cycling, but really any exercise has been proven to show a benefit. A structured walking program, this kind of outlines it. Our goal is to do 45 to 60 minutes at least 3 times a week for 12 weeks. Now, most patients, when they're starting out, can't do that, but you're going to work up to that. You're going to walk as far as you can before you get pain. You're going to walk through the pain until it's really not tolerable anymore, and then you're going to stop and rest until you're pain-free. You'll resume that and continue that cycle for that 45 to 60 minutes, doing that 3 times a week for 12 weeks, and believe it or not, you will walk farther with just exercise alone, and a lot of patients are very satisfied by that. When patients do require treatment, and so these are the patients that have failed their walking program despite really trying to walk, they are still, their quality of life is very affected, or they have non-healing wounds or rest pain, we can offer endovascular options, minimally invasive options with ballooning and stenting. We do open surgery like bypass surgery. In some instances, we do have to do amputations. And then we also do conservative management like wound care and optimizing your medications and your comorbidities. This is just a picture of a minimally invasive or endovascular strategy. We typically go through the groin arteries or the femoral arteries. We take pictures with contrast, and we use balloons and stents to open up the blockages. The open surgery, sometimes we remove plaque, something called an endarterectomy, where we put a patch on top of the artery and close that up. Sometimes we need to do bypass surgery. Depending upon your anatomy and what you have, we make a plan. But this is more obviously invasive and a longer recovery time. We also know that it's really important in patients who have wounds, particularly diabetic wounds, that having an interdisciplinary approach, or endocrinologists, vascular surgeons, podiatrists, all working together, those patients do much, much better than patients who are seen sort of in silos. And comprehensive interdisciplinary foot care programs have been shown to reduce amputations by up to 86%. So really important. In Charlton, for instance, we have a wound clinic right in our office, so we work hand in hand to take care of those patients. Really important, where you're communicating with your endocrinologist and all working together to try to heal your wounds and keep you wound-free. We have something called a Limb Preservation Center at UMass. This is in our Worcester, Milford, and Charlton locations. We coordinate care with all your different doctors to try to optimize your health and reduce your risk of limb loss or amputation. like I mentioned, we have on-site vascular lab testing where we do your ultrasounds in our clinic, and we share a space with wound care providers, which is very helpful. When we think about amputations, it's really three things that contribute to it. One is your vascular disease. So peripheral arterial disease, not having enough blood flow, if you get a cut and can't heal it, will contribute. An infection will cause wounds to not heal and increases your risk of amputation, and pressure. So diabetics in particular get something called neuropathy, where they can't feel the bottom of their feet. And unlike a patient who doesn't have neuropathy, they won't feel when they're stepping on something sharp or when they have a lot of pressure on the foot, and that can promote wound development. And all three things, if they're together, it's really, really hard to prevent amputation. So we work on all of these aspects of amputation prevention to try to help our patients be amputation-free. What is a diabetic foot ulcer? This is an open wound or a sore on the foot. Patients with diabetes have high risk for foot ulcers because of that neuropathy. They just don't feel when they're hitting something hard. They, don't get the feedback to stop putting pressure as they're doing. And that's related to nerve damage or neuropathy and peripheral arterial disease. What if you get a foot ulcer? So this patient here is looking with a mirror at the bottom of his foot. Most patients can't see the bottom of their feet, and if you have neuropathy and can't feel if a cut's developing, that's a recipe for an infection, an open wound, that sort of thing. So it's really important to keep an eye on your feet daily. If you notice that you have an ulcer or a small cut, important to see your doctor immediately. You'll likely be referred to podiatry, and in some patients they also need vascular surgery if they don't have enough blood flow. So can a foot ulcer be prevented? The answer to that is yes. It's really important to have good blood sugar control, know what your hemoglobin A1C is and optimize it. Take care of your feet, check them often, get a mirror if you can't reach down to actually look at the bottom of your feet, use a mirror to see the bottom. Another thing that patients don't really think about is that bath water can burn the bottom of your feet, and if you have neuropathy, you won't feel that hot bath water. So test it before putting your feet in. Don't soak your feet. See your podiatrist for toenail clippings. Protect your feet. Wear good fitting shoes. Wear closed-toed shoes. Don't walk around barefoot. And of course, avoid smoking. All right, that was a lot all at once. And so I wanted to stop here before I give the mic over to Lisa, who's going to talk about our varicose veins. And yes.
I'm just back on your last slide. Do
Yes.
not soak your feet.
Yes. So if you have an open cut and you're soaking your feet in dirty water, that will just promote infection.
Okay. Gotcha. All right.
That one that's specific to diabetics, and that's why a lot of times they don't know there's a crack even in the skin,
Yeah.
and that soaking is what the issue is.
And then you'll get bacteria.
I always tell people if you can't give up your bath, just make sure you turn the shower on at the end and rinse your feet really well, and that will help mitigate a lot of that. 'Cause there are some people that love their tubs.
Yes.
Right.
I have a question about the calcium deposits.
Yeah.
Now, how do they get into your veins like that?
So it's all atherosclerosis, and as your cholesterol builds up in your bloodstream, it just latches on. It's very sticky.
So it's already in the blood then?
Oh yeah, you have cholesterol in your blood, and as you smoke, you have diabetes, extra sugar in the blood, and you have high cholesterol. That all can get deposited on the blood vessel walls.
Okay, but it's going into the arteries, not the veins.
We're talking about the arteries,
Okay.
correct? Yep. Yeah. All right.
Okay.
We'll move on. Yes, no problem. We're going to now move on to the vein portion of the talk.
Swap. So hi everybody, I'm Lisa. I'm the nurse practitioner that works with Dr. Boitano in Charlton and everywhere else, and I'm kind of the vein lady. It just became my thing as I joined Vascular several years ago. Veins are the alternate vessel. The arteries we just talked about. The veins we always think of as a little bit less scary unless there are certain things. Varicose veins are very common. We all have veins in our leg. They are working against gravity up the legs, and they're bringing the flow back. So I always think of arteries bring the flow out, veins bring the flow back. There's a deep vein system and a super vein system. This deep vein system brings 90+ % of the blood back to the heart, and the superficial system is responsible for the rest. When the veins are working well, you don't have any symptoms and they don't bother you. When they're not working so well, things can happen. So, all along the vein, there's little valves because, as you can imagine, if they're working upwards against gravity, something needs to prevent that backflow. The medical word for that is reflux. So there's valves all along the inside. Over time, for multiple reasons, they can become damaged or less effective. When that happens, the valves are not closing tight enough, allowing that blood to backflow down the leg. Then it sits in your veins, you get stretch, dilation, and pooling. A lot of people start to get what I describe as aching pain the most. They will get some throbbing. Their legs are heavy. They get fatigued. They find they can do less activity without them feeling like they just weigh a lot. The legs can then start to swell. In addition, you start to see some of these ropey veins along the leg. They get bulgy and very unattractive, big blue things, and your skin can start to change color. Kind of reddish, brawny, or brown, as that, it's called hemosiderin, it's a component in your blood, starts to leak out, and it stains your skin. If this becomes severe enough, you get a lot of swelling, a lot of thinning of the skin, and then you start to get actually wounds on the legs from this. So these are little examples of tiny little spider veins. These are cosmetic, these are pink. We all know what those are. These are varicose veins. They're kind of large and bulgy. Sometimes you don't always see them. You see a lot of swelling and a lot of discolor with skin changes, and that's our cue that those veins are a little bit deeper, and the ultrasound we do is going to show us those veins. You can see here this person right on the ankle. That's the number one spot. They get little breakdowns and they start to get wounds, and they're very hard to heal. When you have swelling with this, it becomes the path of least resistance and everything starts to leak out. Cramping can also come, so we want to differentiate with arterial disease. Sometimes people do describe restless legs at night, and they can get intense itching, which then becomes a problem because if you scratch this, you're going to get a wound, and then again, that's hard to heal. So who is at risk for varicose veins? People who have had a blood clot in the past. Not everybody, but a lot of people have a large clot that gives them chronic swelling and some type of blockage because it scars the vein. People who have surgery, I see a lot of patients that for the first time after a hip replacement, knee replacement, or even young people with an accident that injures the legs and requires surgery, they have a lot of persistent swelling and vein symptoms that come too. Pregnancy, as you can imagine, puts a lot of pressure on the veins. Multiple pregnancies, higher risk. People that gain weight, again, it tends to put pressure and helps them to be less effective. And family history. Family history is number 2 in my eyes of risk factors for vein disease. A lot of people see it run in their families. This is also assessed with an ultrasound, so it's not painful. We also have this in our lab in Charlton. There's little pressure gradients that the tech will induce to try to measure that speed of backflow, reflux, and then how big is that vein, and what area on your leg, because there's multiple veins, is not working at the greatest, and is there potentially an area that Dr. Boitano could make better for you. How do we make symptoms better? So we ask everybody when they first come in, have you tried walking more? Believe it or not, walking is better. You use those muscle pumps, it improves not only that venous return back, but also the lymph fluid that wants to collect and make swelling. So I tell people try to walk 20, 30 minutes every day if you can. Doesn't have to be all at once, but that function will help a lot. Elevate your legs when sitting. Standing like I am for long periods or sitting like you are will always make this worse. Moisturizer, so that when your skin is dry, it doesn't get as itchy, you don't scratch it and make a wound. Healthy weight, and then everybody's favorite, compression socks. When the socks fit you well and appropriate, they are not painful. There is short, there is tall, there is wide calf, there's a million versions. I've also discovered a really effective compression legging, a company that makes them. Same compression as a hose, so it's a lot easier to get on. So we really try to work with you, and there are places that we work with who are trained to measure for good fit. I try to encourage everybody to get measured because then the stockings fit you and you wear them. Daytime use, take them off at night. And that's when you moisturize your legs. So can we treat them? Yes, and we kind of offer this wonderful plethora of different treatments. The first one, radiofrequency endovenous ablation. Basically, Dr. Boitano takes a long, thin wire that has a little heating element at the end to heat up the inner lining of the vein to close it down. With a similar mechanism, that would be VenaSeal, but that's a medical glue, believe it or not. They've created a medical glue that's safe to inject in the vein, and it sticks it down on itself so that that part of the vein is not working anymore, and the other veins in the leg take over. Sometimes people have had long ago procedures where they used to take you to the operating room and rip those babies out. That gives you a different kind of tortuous curvy vein when they recur, and that's when she might recommend something called phlebectomy. Tiny little micropunctures pulling up the vein. She interrupts it with little cuts, and the rest just shrivels up and goes away. We now have the ability to use a foam sclerotherapy. That's an agent that requires only 1 or 2 pokes on the leg, and it goes inside the vein as well. Irritates that lining so that it closes down, spasm, and then that becomes ineffective. I'm your girl if you don't like the spider veins. That's cosmetic. Insurance doesn't care, but I do, and it makes it pretty. We do all of these, believe it or not, in the office. It is in Westboro because that's where all of our equipment is. We are now doing this procedure, however, starting, I believe, next month at Harrington. We've gotten some OR time there, so that can be done there. But the other equipment's expensive, and we haven't got to the point where we can have it in 2 locations. But you never know.
How expensive is the equipment?
A
I'm
lot.
just curious.
It's thousands and thousands of dollars. That's so, we actually have quite a big vein practice here. We really do, I would say, but we have a big both. So there's always the possibility as time goes on, but right now everything in medicine is try not to be redundant, try not to spread yourself thin. So we're seeing where it goes, and if it's something that's legit, we might be able to do it in the future, but I don't know. And Westboro's not that bad. I live out here too. You just get on the pike, you hop off, it's right there. So.
And we can do all your follow-ups in Charlton, which
Yes.
makes it very easy.
Everything before, everything after here. Yes.
Does insurance cover?
So yes, the insurance does not cover for the spider veins, of course. I'm sure you know that. But what we do is the information that's on the ultrasound, there are specific criteria they ask us, as well as have you trialed the compression, elevation, and walking. We have to attest that you've done that. And the majority of the time it's covered, yes. It's pretty straightforward what they require. And I have to say, really, it's pretty consistent. Medicare does not hassle us. Everybody always asks me that because usually you're my Medicare group. They really, if we do the right things, they pay for it. People get a lot of relief. It really can impact their everyday activities because they find they're becoming less active, which is the worst thing for everybody. The more active, the better we are. And it's the heaviness, the aching, and their legs just get really tired. And it really does change that for people. It's a good procedure.
You just mentioned that there is some equipment now available at Harrington. Does much of the surgery get done at Harrington or in Worcester?
So the phlebectomies we're starting to do at Harrington, but the rest of it is done at the vein center.
In Westboro.
Yes.
Oh, Westboro.
It's in Westboro, yeah.
And even for the aortic?
All of that is in Worcester.
Worcester.
Surgery is, but everything
Surgery.
else is here.
Yeah, we can do surveillance, follow-up visits. All of that can be done in Charlton, but the actual surgery we do in Worcester.
Okay, and follow up on that, I know you're mentioning there 10 North Main Street. and
Yes.
I think most of us know where that is.
Yes.
But am I correct in noticing that when I go on 20 toward the Pike, there's a place that says vascular surgery?
It's a private practice. It's a separate group.
Oh, okay.
Yeah. So
But you're
we're
correct.
part of UMass. We have locations in Charlton, in Worcester. We do all our surgeries at UMass, and this is our location. Yeah.
Oh, okay, thank you.
Yes, sure. Anybody else?
That website, umassmemorial.org, can I get other information on the webpage there
Yes.
as well? Okay. And you
Yeah.
both have emails that? okay,
Yes, it
great.
links right to it. Absolutely.
Okay.
And if you have my chart, if you search for our name, you can message us directly. Thank you so much for your time,
Thank you for
everybody.
having
It's
us.
nice to meet you all. Thank you.